So with that, let me start our introductions. We have a really fantastic panel today. And first, I'd like to introduce our co-moderator, who's been a friend and mentor of mine for a long time and someone that really needs no introduction to this audience. That's Dr. Verily. She's the president-elect of the American Academy of Neurology. Verily has held numerous leadership positions in neurology as a field and in media. She's the past chair of the AAN Medical Economics and Practice Committee. She's editor-in-chief of Brain and Life magazine. She also holds academic appointments both at New York Medical College, where she's a clinical assistant professor, at Yale University School of Medicine, where she's a clinical instructor. Verily, thanks for joining me today. It's great to have you.
It's great to be here. Thank you very much, Gordon. And I want to welcome everyone to this event. I'm very excited to take part in it. And I'm most excited that there are so many medical students who have registered to join us. You are our future, and the fact that you're listening to a program like this about healthcare gives me great hope that we will have lasting transformation in healthcare. So thank you for being here.
Thanks, Verily. We have a really diverse audience here today, which is exciting. It's roughly evenly split between individuals who are in training, residents, students, neurologists. We even have administrators here, which is great. So with that, let me move on with introducing someone else who really needs no introduction. And it gives me great personal pleasure and excitement to introduce Dr. Vivian Lee. I had the pleasure of working for Dr. Lee and have witnessed her vision and innovation firsthand. A colleague of mine told me it was actually rather tiring working for Vivian because the brilliant ideas and innovations kept tumbling out, and I think you'll see that today. It's actually very energizing. Amongst her accomplishments, she's now an author. Her new book is called The Long Fix, Solving America's Healthcare Crisis with Strategies That Work for Everyone. I've read it and found it really informative and engaging, and certainly something I would recommend for our students. Dr. Lee is currently president of health platforms for Verily Life Sciences, which is an alphabet company. We'll hear more about that as we go. She's a senior lecturer at Harvard Medical School. And Dr. Lee really is a healthcare visionary, I think. She's been named by Modern Healthcare as one of the 50 most influential clinical executives in 2020. In 2019, I think she was ranked 11th in Modern Healthcare's 100 most influential leaders in healthcare. We don't know the 2020 data yet, but I think these speak for themselves. She's a member of the National Academy of Medicine. Dr. Lee, welcome to Neurology on the Leading Edge. I know I speak for everyone on the webinar now in saying how grateful we are you're here, how excited we are to have you. But maybe we can start by having you tell us a little bit about who you are and what you do.
That's great. Well, thanks, Gordon. It's great to be with you, and it's wonderful to see you again, Dr. Avitzer. And I want to thank all of the AAN staff for putting together this event. I know these virtual events can be a little bit complicated, so really appreciate all the dedication and attention. So it's really wonderful to be with all of you. I have to say that I also felt the same way as Verily did, that I'm just thrilled that there is such a mix of people in attendance. In my view, there really couldn't be a more important time than now for the engagement and activation of everybody in thinking about our future in healthcare. I think that the coming decade is really going to be a defining one for our country, and in large part centered around healthcare and what we do about healthcare, how we re-envision it, how we redesign it, and how we really deploy a better system. And the COVID pandemic, of course, has made it even more evident, the urgency, the need for change. And I think everybody is actually more ready for change. So even though I called my book The Long Fix, expecting at the time, because it was written before COVID, that it would take decades before we would really move forward, I think right now we're seeing accelerated change. And that's an opportunity for us, because we, of course, hope that that change is for the better. Gordon asked a little bit about what I'm doing now, and I'll say that, so most of my career has been in academic medicine. I had the privilege of working with Gordon at the University of Utah, was the CEO and the dean of that system, and the senior vice president for 6 years. And at the end of my tenure there, I had a year sabbatical. And I really thought about another CEO position. Actually, I had the offer in hand. I already called up some people to see if they might be willing to move out there with me. And then this offer came back around again from Verily. And Verily is Alphabet's healthcare company. It was originally called Google Life Sciences, and it was rebranded. We were created when Google became Alphabet. We are one of the bets of the Alphabet family. That's a joke. And so we're purpose-built to commercialize healthcare and life sciences products. And I came to Verily because, having spent all of my life in academic medicine and become really focused on how we can improve healthcare, why our healthcare system in this country is so uneven. It has some of the greatest of the greats, but also we have some of the worst, statistics in terms of performance, given how much we spend on healthcare and how poor our healthcare outcomes actually are as a whole. I was really curious about why that was the case, and I was very determined to try to do something about it. And the folks at Verily said, when they came back at me the second time, they said, well, if you go to another healthcare system, hopefully you can help improve that healthcare system and improve life there. But if you come to Alphabet and you come to the Verily family, you can just come and do your book. Your book is supposed to be about fixing healthcare, and so maybe you can just come and implement some of those ideas. And so that's actually how I ended up working for a health technology company. So I've been reflecting a lot about, and I'm looking forward to having this discussion. The book was originally really written about, it actually was originally written for medical students. I originally wrote it based on a series of lectures that I gave to the first and second year medical students when I was at Utah, trying to explain how our healthcare system works and the business of healthcare, all of the things that I wish I'd known before I'd gotten into healthcare. And I certainly wish I'd known once I was in healthcare. That took a long time for me to really, really understand. And having written the book and having had the chance to interview more than 100 people across the country about some of their really great ideas about how to improve our healthcare system, I really wanted to have a chance to share those thoughts with a broader audience and really engage people in how they can, and how they and all of us can really work together to fix our healthcare system. I'll tell you one example. So as I was going around the country, I think the pivotal lesson and the core argument of the book is that fundamentally our business model of healthcare is flawed, that we have a fee-for-service model of healthcare, which really rewards more services, more procedures, more expensive technologies, including radiology, MRIs, for example, more operations. And instead, what we really need is a system that rewards better health, because that's really the goal of our system. And as I went around the country, I came across many examples of how a business model designed around rewarding for better health could actually be more successful. I'll tell you one example. I know this is top of mind for many practicing neurologists who are generally not as much proceduralists as others. And so this is a story about the folks at Chen Med. Chris Chen, whose father actually founded this group, started in Miami and now extended across the country. And it's a Medicare Advantage model where instead of being paid a fee for service, instead of Medicare paying you for every procedure and every patient that you see, they have a different model where they pay the medical group a fixed amount of money to care for a set of patients for the whole year. And that amount is determined by how well or sick those patients are. So it's risk adjusted, as they say. But once you have those dollars, the doctors have the latitude to decide how they want to spend the dollars to keep those patients healthy. And of course, the first and most important thing is to keep them healthy and out of the hospital, since once they've been paid that fixed amount, if they ended up spending more money, for example, on a hospitalization, that would be affecting their bottom line, affecting the physician's bottom line. This is the new payment model. And so as a result, the doctors completely changed the way they practice. They spend a lot more time with the patients. They actually invest in transportation. They had on-site pharmacy. They invested in yoga and Tai Chi classes for falls prevention. And while the investment in primary care and in spending time with the patient up front was far greater than a typical primary care practice, in the end, they were really able to reduce hospitalizations and, of course, keep their patients much healthier. Those kinds of models, I think, are the direction in which our country is going, more value-based payments. I think there's a lot more appetite for that also now, post-COVID. And that's really what the book is about. It's about how do we think about models where we are driving better health outcomes? What does it look like for patients? What does it look like for providers and delivery systems? What does it look like for a couple of other industries that I look at, the pharmaceutical industry and big data? And then finally, I look at a couple of payers, both one chapter on employers and then another section on government paid healthcare. And I focus actually on the military health system in the VA as I think really interesting government-run healthcare systems that we have a lot to learn from. So those are some of the thoughts that I wanted to share with you to start out with, and to say that I think that we're living in a time where there is going to be enormous change. And I really hope that the neurology community and those of you who are students getting into healthcare now will really be part of the definition, part of the drive towards a much better future for us. And so I'll stop there, and then I'm happy to engage in some conversation with Orly and with Gordon.
That's fantastic, Dr. Lee, and it really sets us up for where we really wanted to begin the conversation, because these days everything really begins with COVID-19, doesn't it? And particularly excited to hear more about your positive vision for the future of American healthcare. You talked a bit about kind of our widget-based system now, and the fee-for-service model, which in your book you refer to as an action-based system, an action-based economy, as opposed to one that's really outcome or results driven. And as I know you're aware, not all neurologists, but many, if not most, are so-called cognitive specialists. In other words, we don't really do a lot of procedures, but we interact with patients and think deeply about their problems. I'm curious, how has the action-oriented medical economy impacted non-proceduralists in the age of COVID? And you touched on this a bit, and I'm really curious to hear more, about how can we take advantage of this crisis to better value cognitive and preventative care going forward?
Well, we are definitely seeing that in a fee-for-service model, or as you alluded to in the book, I call it paying for action. In a paying for action system, we are really rewarding, we're rewarding for more services and more actions. And that's what's led to the proliferation of imaging centers, of surgery centers, of cancer centers, of any kind of healthcare business that actually produces lots of services, lots of procedures. And we've actually created a healthcare system that is referred to by the economists as supply-driven demand, meaning that if you are running a healthcare system and you want to improve your revenue, you build more of these services. And then of course, we just simply refer more and more patients to an MRI. I'll pick on my own field since, you refer more patients to an MRI, even if you're not 100% sure, even if they don't necessarily absolutely need it, maybe the patient is hoping you'll do something for their back pain, so you order an MRI just to placate them, or a brain MRI for a headache. That would be something very familiar to this audience. And so as a result, with supply-driven demand, with the financial incentives as they're set up, then inevitably we tend to reward those physicians who are able to generate those revenues. And in fact, I tell the story of when I first landed in Utah, or now one night I was late in the office and I just was walking around the back halls of the hospital, and I was looking at some brightly colored graphs sort of caught my eye in the back halls. And they were charts about the different physicians in that particular division. And the charts were, as you might expect, all about RVUs. They were all about, for the medical students, they were all about the productivity of our physicians. How many catheterizations had they done? How many echocardiograms had they done? And of course, the top physician was defined as the one who had done the most. And I remember thinking at that time, because I was preparing for a lecture for the medical students, what would we really want there? We really want who actually maybe made patients better, and even ideally who prevented an illness, who was able to do that at the lowest cost, most efficiently. But because we've been valuing services and because we have this fee-for-service model, that's not what we're seeing. So that's also what has led us to value proceduralists over cognitive specialties, for example. It's just fundamentally in the business model. What we're seeing now in COVID is that this fee-for-service model is not, in addition to all its other many faults and limitations, it's not a particularly robust or resilient system. So once you stop performing services, you have no fees. And that's why in the heat of COVID, especially in April and in May, we saw while ERs and ICUs, especially in some parts of the country, were really getting inundated, the rest of the hospital was empty, clinics were empty. And so I think in the month of April alone, we furloughed more than 1.5 million doctors and nurses, which is sort of unimaginable because we know we have a shortage of physicians and certainly a shortage of nurses in this country. So the idea of furloughing them. And what we saw actually with folks like ChenMed and some of these organizations that were paid on more of a value-based, more of a capitated model or a global model, the VA, the military health system, ChenMed, was that they were actually able to go through COVID much more effectively. They had what Chris Chen called a subscription model. He was getting paid every month by Medicare regardless. And so he was able to use those dollars and actually help provide care to his patients, whether it was home-based visits or converting one of their clinics into an urgent care center so they wouldn't have to go into the emergency room where they were very afraid to go. And so it just created much more resiliency. And as a result, I think we're seeing healthcare systems as well as payers much more willing to consider alternative models of payment than ever before. So I think that's one very significant outcome of COVID.
That's derivative of this. And basically put, it sounds great that we'll have a future world where neurologists have more time to spend with their patients. That time is valued appropriately. But what about patient access to care? We struggle with this. We certainly don't have enough neurologists. Do you have thoughts and kind of the future, how we can approach access to care for all?
Well, that is such a core issue because I think that, as I mentioned, we already have had issues of access before. And of course, the access we can describe in so many different dimensions. But first of all, we had about 10% of Americans were uninsured and many more were underinsured before the COVID crisis. Now with rising unemployment and the fact that we have employer-based healthcare, I think we're seeing it's about 13%, over 5 million additional Americans lost their employment and have lost their healthcare. And of course, depending on what state you're in, you may or may not be able to move on to the Medicaid rolls. So that's been a huge issue. And then of course, access because of concerns about coming in with COVID. And then fundamentally just the shortage of certain kinds of specialists and basic access issues in rural and underserved parts of the country. So access is a problem, and it's just been made worse, I guess, is the main moral of the story there with COVID. But what we have seen is a much greater willingness to think about digital health and telehealth. And I'm sure many of you are working in institutions that had very few telehealth visits a few months ago, and now, at least, especially in the peak of the summer, we're just doing all telehealth. And I know that all of you who are practicing are familiar with the relaxation of many of the regulations, as well as the willingness to reimburse for telehealth, which has really dramatically changed that landscape. I have a couple of points, I guess, to make about that. I think that I'm going to make maybe two different points. One is that with respect to shortages of specialists, and especially in rural and underserved areas, Gordon and I were both in Utah. That's an area with a very large frontier and large communities that really have very little access to care in Utah, Idaho, Wyoming, Montana. And one area that I have often talked about, even though I don't think it's as well known on the East Coast or on the West Coast or areas that are more highly densely populated, is the physician-to-physician consulting. Project Echo started that in New Mexico with physicians who had expertise in hepatitis, advising through teleconferencing, primary care docs, family medicine physicians, people who just didn't feel that comfortable with complicated cirrhotic patients. And then that's now extended to a wide range of other kinds of conditions. When we were in Utah, I remember one of my favorite groups was the group of child and adolescent psychiatrists who would consult with pediatricians and family medicine physicians, in all kinds of rural towns, all over the West, and advise them when they had kids who had eating disorders or who had depression and help them manage that. That work was all done pro bono, but I think that for folks like you guys, especially in where there are so many shortages of neurologists, thinking about advocating for some kind of a model where physician consulting is also recognized as a valuable service, I think could be worth thinking about. I haven't heard that talked about much, but I'd like to say that could be very important. On the other side of the whole increasing access, or maybe just moving beyond telehealth, would be also thinking a lot more about digital health and how do we offer beyond the ability to simply talk, to visually engage with people on a screen or chat or over a phone call. How can we actually provide more than that for our patients with digital health solutions? And so I think that's probably, I'm happy to talk a little bit more about that, but I think that's another dimension of how we provide greater access to people outside of the four walls of the clinics and the hospital.
So maybe one other question on this topic, and another great question that came from one of our participants. So as cognitive physicians, how do we kind of work to move the needle on changing the focus from kind of the action-oriented system, more services equals more money, to healthcare? There's a disincentive to change this model as facilities, practices, suppliers, proceduralists, they don't want that change, right? So it's sort of the winner-loser argument, and kind of the concept that in the future value-based world, the very things that are revenue centers become our cost centers, right? And that's a real disruption. How do we go about kind of moving that as a system? And then are there things that individuals can do to engage in this?
Yeah, this is a conversation that I often have with my radiology colleagues. I think it's clear that we're going to go through a significant change in payment. Our payment models are going to change because you may say that the hospitals or obviously the surgery centers want to continue in a fee-for-service model, but the payers don't. And one statistic that I just read a couple of weeks ago, the Congressional Budget Office, I think, came out with a new estimate of the Medicare Trust Fund. The fact that given the downturn in the economy, originally the trust fund was projected to run out of money. This is part A, this is the part that pays for hospitals, which is probably among the most important. It's the part that our taxes are going to pay for. That was slated to run out of money in 2026. And the latest projection that just came out in early September is now it's going to be 2024. So a colleague of mine, Liz Fowler at the Commonwealth Fund, said to me, she said, if you leave it to Congress, where you might prefer a scalpel, when Congress is faced with the need to cut the budget, they tend to resort to an axe. So I think we're really looking at some significant changes that are going to be underway in payment. And the fact that actually increasingly hospitals and other systems are willing to consider more value-based payments, more global payments, capitated payments means that I think we're going to see some change. There's the financial pressure to change and there's increased willingness to change. So what I think that means for all of us is that we really need to think about how we deliver value and how do our services improve health outcomes and reduce the cost of care for the patients that we care for, and how are we able to demonstrate that to the people who are paying us. I have the same conversation with radiologists where we were we were the cash cows in a fee-for-service model. You know, I didn't even know it because I was working for a university hospital and I was paid a fixed salary and mostly writing grants at the time. But most of my profession, you know, we're cash cows for most systems. And now it's really completely flipped. It's in a value-based model. If the health system is paid a fixed amount of money to care for the population, we're now a cost center, as you said, Gordon. Every time we do an MRI, it's an expense to the hospital. It's no longer something they can just bill somebody else for. Like in the Medicare Advantage model that I mentioned with Chris Chen, they definitely don't want all their patients going and getting MRIs. So what does that mean for the organization or for that profession? It really means that we have to think about how do we drive more value? How do we actually improve outcomes at lower costs, and how do we measure it? And it may seem easier for, say, the surgeons who can, say, define, you know, in a specific episode of care, like a total joint replacement or a CABG, there are relatively clear outcomes measures and the cost of care can be very well defined, and it may seem harder for people who are managing chronic conditions. But I think it can also be done. And maybe one example would be in the work that we're doing at Verily around the management of chronic diseases with digital solutions, but the idea is still the same. So we have a company called Onduo, which is a digital health platform for chronic diseases like diabetes, type 2 diabetes, hypertension, weight loss, mental well-being, and so on. But for, say, diabetes, you know, it includes a continuous glucose monitor to measure your blood sugar so you don't have to prick your finger multiple times a day. The sugars go, you know, the sugar values go to your app. You can see the tracings. You can take pictures of your meals and snacks. You can manage your blood sugars, I think, really effectively. It's actually very engaging for people to see, visually associate what they're eating, how they're exercising, and how they're sleeping with their blood sugars. They can text with a coach. They can video conference with a coach. And overall, we're seeing with our solution and with others, so that this general approach has very high levels of engagement, and people really are able to sustain improvements. Now, when we think about it as a business, we could simply recapitulate the fee-for-service model and say, yes, we're going to charge every time you click this button, and every time you text with the coach, we're going to charge you. But instead, actually, we've said, well, you know what, we only want to get paid for lowering HbA1c or for improving other measures of diabetes wellness. And that's actually how we've structured our deals. We've said, okay, we're going to really embrace this whole idea of value. And we think we should be measured based on our ability to lower HbA1cs and to at least maintain or even lower the cost of care for patients over time. And so I guess I would challenge the neurology community, and many of you I'm sure are already doing this and thinking about this, but for the patients that you care for, how are you able to quantify the outcomes, the impact that you're having on your patients against the cost of the services that are necessary? And ideally, I think cognitive specialties have a real advantage because it actually costs less to care for patients outside. It actually costs less in most cases for cognitive care, aside from some rather expensive infusions, than it does, say, operations and, you know, high-end procedures for the hospital. So you should be able to make a strong case for it, and particularly as the population is aging. So many of the conditions that you care for, if we can keep your patients healthy and out of the hospital, significantly lower costs.
Dr. Lee, you've made a very compelling case, obviously, for value-based care, and whether we're in the old, current, traditional system of fee-for-service or in value-based care, I think what we've learned during COVID is that our most valuable asset is our providers and their staff and the people on this call. And as our practices return to some version of normal, flu season is starting and kids are returning to college and to school, and many of the people on this call are trying to parent and balance providing their children with home-based e-learning and their job responsibilities. So how do you see the next few months playing out, and what can we do to better support that most valuable asset, which is the healthcare provider?
That is such a great question. So I have to say, I feel very fortunate because our children are teenagers and in college. We have four kids. And I just sometimes think about if this had happened when they were all in diapers, and I'm very sympathetic. Our workforce at Verily is many folks are young parents, and the idea of remote learning is one thing when you have teens, but remote learning for kindergarten, I think that's kind of or elementary school, it's sort of an oxymoron. So I think that it's definitely a challenging time for many individuals, and I think it becomes ever more important that we really think about how can we make our profession as a whole one that is more rewarding and satisfying. The fact that our burnout rate across all of physicians has been in the 40 to 50%, and I understand in some areas, in some surveys, it's even higher in neurology, is a reflection of a really pressing need for us to take a step back and say, okay, what do we need to do differently? And one of the lessons that I learned when I was at the University of Utah was that physicians are really one of the most motivated and committed and internally driven people that you'll find, right? Just to go through medical school and to get through organic chemistry to get to medical school even. No offense to the organic chemists out there. It's a pretty determined lot. And yet, when we think about solutions to healthcare, when I say I mean like at a policy level. For the most part, I would argue that physicians have really been pretty much neglected in this process in terms of really engaging. And I'll give you an example. When both Gordon and I were in Utah, we were really tasked with improving outcomes. We were already pretty good at outcomes. Actually, our quality measures were very high, but reducing the cost of care. And as part of that journey, we realized that we actually needed more data to quantify the cost of care, figure out what it really cost us to do an MRI or to care for a person with pneumonia or to care for a patient with MS. And in the course of working that all out, we also said, well, we need to measure both outcomes and cost of care for every patient and let every physician be able to see that for their patients. And when we did that, the reaction was mostly about the quality measures. The cost, people said, okay, you're measuring the cost, and we didn't have too much debate about that. But the quality measures invoked enormous range of emotional responses from many of the physicians because they are, so like an example, the chief of neurosurgery said to me one day, he's a skull-based brain tumor surgeon, just a superbly talented individual. And at the time, his department was getting dinged for one of the quality measures was removing the Foley catheter, the urinary catheter, 48 hours after incision. So if you don't remove that Foley catheter within 48 hours, you fail on one of the quality measures. And he said to me, I'm getting this really complicated brain tumor out. Has anyone asked me, did I get the tumor out? Can the patient still walk and talk and function? And all you care about is this Foley catheter. And so what we decided to do was we said, well, actually started with the orthopedic surgeons of all people. We said, okay, you help us define quality. You help us define quality, right? And so the surgeons got together, they called it perfect care. They called it the perfect care index. And they came up with several measures. It had to be evidence-based. It had to be something in the literature. They couldn't make it up, obviously. They came up with several of them, including the fact that this was for total joint replacements. You have to get up and out of bed on the day of surgery. You have to ambulate. That hadn't been one of our measures, but it was clearly true in the evidence. And we said, well, you still have to do the measures. We still have to check off the Foley catheter, measures because we still need to get paid. I'm sorry, but at least you have some latitude to bring in your own measures. And when we did that, I just realized that, our physicians have a lot of insights. They're on the front lines. They're the ones that really know best how to improve outcomes and reduce the cost of care for a system. And it's not necessarily certain policymakers or health insurance reimbursement people who really know that best. And the question is, how do we think about our system in a way that can tap into that expertise and use it as a way to motivate? One of my favorite books is Daniel Pink's book, Drive, which is all about how to motivate people. It's actually everything from motivating your teenagers, to motivating professionals. And he talks about it in terms of purpose, autonomy, and mastery. And for complex tasks, if you really want to motivate people where you have to actually do very complicated, more high-level thinking like medicine, you really need to have a shared sense of purpose, which we all have. But what we're missing is people need to have a sense of autonomy, that they have some control, that they're not just being told what to do all the time, which is happening to us too much in healthcare. And then the sense of mastery, that you've really mastered that. And I think physicians really enjoy that the most. So in my view, a lot of what we're missing in physician satisfaction is that we've forgotten the importance of autonomy and mastery and allowing individuals to sort of express what they think needs to happen, as opposed to inflicting on them the EHRs or certain quality measures that they may not fully agree with. And the more systems can actually broaden that. As we move to value, if we're going to be defining value, let's really think about how patients define value and also how physicians would define value. And I think that's going to be very important. Certainly something that we saw was really engaging and very satisfying for our physicians.
That's fantastic, and there's so much one could respond to. But I realize that we almost got through our discussion about COVID without asking about the vaccine. So if you know when it's coming, we're all ears for that. But the question, tongue out of cheek, is what are the public health implications when we get a vaccine, right? I think people assume this vaccine is going to come and the sun will shine and everything will be glorious. But are you concerned about the reticence of some people to be vaccinated? Are there other public health issues we need to be mindful of, do you think?
Well, the issue of everything around COVID right now, I think, is the risk that we're politicizing what is a public health issue. And I think that's really the challenge that we all are, many of us, I think, in healthcare are really struggling with. We've been, aside from certain very, very contentious issues in healthcare, most of the time when we have a discussion with our patients about recommending a course of therapy, it's usually not wrapped in political, context. And this is really a very notable exception. And I think that's probably my biggest concern, is how do we communicate effectively to our patients and to our communities about the importance of not only social distancing and masking and taking all the precautions now, but also getting vaccinated. And I think we each have a responsibility to do that. So, the book that I mentioned, sorry, I'm just going to respond to the chat, was called Drive by Daniel Pink. Drive by Daniel Pink. Somebody was just asking. I don't think I said it right. So I think that's probably the only answer I can give, Gordon. I do believe that right now there's a real opportunity to that the science of the vaccines is really phenomenal. We're really moving from, I think, all of the traditional approaches that we've used for vaccines in the past, whether it's live attenuated or kind of modifying existing viruses. These new strategies that are being undertaken, I think, are going to have enormous scientific implications for future discoveries and future developments, which I feel very positive and really optimistic about. So just to say something positive about this, and I think the pace at which these vaccines are undergoing these trials is just remarkable. Absolutely remarkable.
So certainly we're all waiting for that, and patients are as well. One thing we also know about patients is that they had a great interest in telemedicine before COVID. One J.D. Power survey showed that it was the #1 consumer thing that people everywhere wanted above all else. And now, of course, almost everyone's had a try at it, both on the physician side and on the patient side. And we initially saw a dramatic shift towards telemedicine, but the percentage of virtual visits compared to in-person visits is gradually going down now. And the question I have for you is ambulatory telemedicine here to stay? And what does that mean for our system?
I'm going to just take it back to, it depends on the way in which telemedicine is paid for. It just comes back to the business model, in my view. If telemedicine is paid for on a fee-for-service basis, which we're seeing, then we will see increased utilization and we'll see pushback from the payers, which we are also starting to see. It fundamentally, like we're just seeing, it's just a complete recapitulation of our basic healthcare system problem, which is that we're a fee-for-service business model. We are incentivized to do more things. And then the insurance companies and other payers push back and they try to deny or they try to put in prior authorization. And so it's just back and forth again between how much can we do and get paid for, how much can we deny and resist. And then at the end, it might fall to some poor patients in the form of surprise billing. And that is really a shame. I think that right now, you know, Winston Churchill said, never waste a good crisis. And right now we're in a crisis, and it's a tremendous opportunity for us to leapfrog into the digital health age, and also in telehealth and in digital health, use a better payment model. Use a model in which we are paid a fixed amount of money to incorporate these technologies, to enable us and our offices to adopt and acquire these technologies, but that we're going to have some investment. And then in return for that, be expected to use these services in a way that really is directed towards better health. I'll tell you a story that in the midst of COVID, I needed to schedule an antibody test. I wanted to get an antibody test because I thought a member of my family might have had COVID. And I called up a clinician's office and I spoke to the administrative assistant. It was not a nurse, it was not a doctor. And as I was asking this individual just to simply schedule the test with one of the testing companies, she said to me, well, I just want to inform you that your insurance company will be billed for this as a telehealth visit. And of course, you know, I'm on this book tour, right? I've just been writing about fee-for-service and overutilization, and I'm just shocked. I said, a telehealth visit? In what way is this a telehealth visit? And she said, oh no, don't worry, you won't be charged at all. There's no copayment for this. We just wanted you to be aware. So I didn't even have the opportunity to deny it. You know, it's going through the system as a telehealth visit. So if that's how we're going to practice, then it will be denied in that same kind of way. You know, we're not going to get the kind of benefits that we need. Whereas, for example, in systems like Kaiser, where they've been doing telehealth for years as an integrated payer-provider system, they've been actually, I think, very wise in how they've deployed it. Telehealth, chatting, they've been doing that for a long time because it's actually more convenient for many of us as clinicians to do it. But we use it sensibly. You know, we use it sensibly. In many cases, we would rather see the patient. Obviously, much of healthcare can't be done just over the video. But I think it's very important that we have the right business model. And then the second thing to say about this is also it does bring up the parallel topic of making sure that that telehealth and digital health don't widen the health disparities gap. I think one of the things that we need to make sure, instead of overutilization and spending so much money just billing for, you know, visits that aren't even telehealth, we really need to be spending enough to have the infrastructure, the broadband access for everyone all over the country to be able to have the access to this kind of telehealth. I think that's actually critically important. So So telehealth raises a lot of issues. It's like everything, it's an enormous opportunity to move to telehealth, and I really hope that we as a nation can really seize that opportunity.
I'm just struck in listening to your discussion there, how much of these issues span beyond healthcare. I was listening to a story about to connectivity and education, which of course is a huge issue. So we have, I think, 13 minutes left. So I think what we're going to do is try to get through as many questions from the Q&A. So we'll kind of go, not rapid fire, but quickly and get your top thoughts on these. And there's no way that I could get through an hour with you, Dr. Lee, without talking about drug pricing. And we have a question from someone else talking about this. You mentioned it earlier. While neurologists may seem like a cheap date, we use a lot of very expensive drugs. And it's one of the reasons it's exciting to be a neurologist now. We have these unbelievable immunotherapies, gene therapy for SMA. So when you actually look at our costs, they're pretty high in that respect. And these drugs are getting more expensive, it seems like, every day. And I think they really pose a challenge for the system. So, how can we provide cost-effective care when, we're prescribing all these insanely expensive medications?
That is a great question. So one of the most difficult chapters for me in writing this book was the pharmaceutical chapter. I thought, having spent, a lot of years in healthcare, that I understood most of it, I thought I did. It took me a long time to dig through some of because they're mostly confidential, but it's really a tangled web of vested interests is how I describe it. And actually, I myself are an institution, as a leader in an institution, benefited from it, because as you talk about these expensive infusions, when I was at NYU, before I went to Utah, I was the chief scientific officer there. And in my first year on the job, we actually sold the residual rights to Remicade for $650 million, which then funded a considerable amount of the research investment that I was able to make in the institution. So we're all sort of tangled up in this. And so it really creates, it's a very difficult problem to untangle. It really is a Gordian knot that I think we have to address. So, and I think it's actually very important for specialists like neurologists, as well as oncologists and others who are prescribing these high-end drugs, because they're critical for these patients. And yet they really do run the risk of that, as Liz Fowler said, the axe approach rather than the scalpel. At some point, country can't afford it anymore, we're doing the axe. So I think we need to really try to figure out how we can avoid that situation. And one of the stories that I talk about in the book is the work of Peter Bach at Memorial Sloan Kettering. So this is a cancer example, but hopefully the parallel applies to neurology. Peter Bach is an oncologist, and he has put together a website called Drug Abacus. And it basically looks at the cost effectiveness data of, I think it's top 50 oncology drugs that he and his research colleagues track. And we know that in other countries, like the UK, like in Canada, there are actually governmental bodies that look at the cost effectiveness, and the cost effectiveness or cost utility analysis of these drugs factor in to what they're willing to pay. In the US, we have had some resistance, although there's now, I think, increasing openness on the part of many of the pharmaceutical companies to this. But there was a lot of resistance early on to investing in cost effectiveness research. In fact, when PCORI was created, the Patient-Centered Outcomes Research Institute, it explicitly says in the legislation that we're not allowed to talk about quality adjusted life years. This measurement of cost effectiveness is actually prohibited in any PCORI funded grants, which is frankly shocking. But I think right now there's greater willingness to support that, and we're seeing it from everywhere from Troy Brennan at CVS actually announced that he actually wanted to have a quality threshold for medications on formularies, to, for example, the VA and the military health system, who've actually who are allowed to use these cost-effective analysis to look at their own formularies. So this is a little bit of a winding answer to say that I really would encourage the neurology community to be very proactive and pretty aggressive about transparency in terms of the cost effectiveness of the medications. I mean, you, as this colleague of mine, Len Saltz at Sloan Kettering said, you know, when I talk to my patients and they ask me how much is this going to cost, with out-of-pocket and co-payments, it can cost your patients a lot these days. And, you know, I think it behooves us to really be looking after them and their interests now, and as much transparency as possible, I think would be very helpful. There's a lot of opportunity now for biosimilars. There's a lot of opportunity for increasing competition in the market, but we have to support that with, I think we have to support that with more transparency. And then as a nation, we have to definitely invest more in cost-effectiveness research.
We have another question from the audience asking, do you think that practicing defensive medicine due to perceived medical legal consequences of ordering fewer tests and procedures has an impact in this value-based system, and how can that be better managed?
That's a really interesting question, the defensive medicine question. I think there have been some studies that actually looked at the variations in practice from states that had tended to have higher levels of litigation or higher, you know, the awarded dollars were, you know, gazillion dollars, as opposed to where they're more constrained. And there actually were not significant differences. So it's not actually that clear to me. Some people have estimated how much of the overspending in healthcare in the US is really based on defensive medicine. And it's not as high as people say. It's not as high as people say. I do talk a little bit about no fault insurance kind of approaches. Denmark, Sweden, New Zealand all have these no fault systems. And so, and the results there are actually, you know, I can go on and on about that. We also actually have a couple of states, I think it's Florida and it may be Virginia, actually, that's your state, that has no fault for complicated births, where there's a no fault fund for baby, you know, for families who have babies. And so we do have some models of that, but overall, I'm not really, I don't believe that the, well, how should I say this? Overall, I think that I would say it's less about defensive medicine. And where I would really point the finger more is at the expectation of many of our patients that after they see us, they will walk out with a prescription or an order or something. I actually fault that more than I do defensive medicine. Like, I think the reason why so many kids have these antibiotics, you know, the pink stuff when they come out with a runny nose, is because the parents actually expect it, not necessarily because the pediatrician is afraid of being sued. So I think a lot of the choosing wisely work, you know, really trying to educate parents and educate the public. And I try to do it in the book myself, which is more is not necessarily better. And in fact, more can often be dangerous. So, thanks for that question.
So I think we have time for one brief question, and I want to try to kind of combine two into one in recognition of the number of students we have and residents we have. I think, I don't know, listening to you, certainly reading the book, I'm left with optimism about our future, and I'm hopeful that they all will be able to practice with the same joy in their profession as, you know, we have been able to. The specific question is a little afield for that, but I think it's aligned, which is what impact will a value-based system have on medical education? You know, will the fact that we're not in an action-oriented system help us focus less on productivity and more in educating our students?
Yeah, a value-based system, you know, one of the things that always struck me, because I became a radiologist not aware of the fact that at that time radiologists were, I think, compensated as much as orthopedic surgeons. They were number one and number two. I didn't know that. I went into radiology because I actually was really interested in MRI and the physics of it. So what I was struck by in my years when I was on the selection committee as a radiology residency was a number of people who would come in and say, yeah, you know, I really want to be a radiologist because I'm a visual person, or, you know, the kind of ways in which people make their career decisions are so much affected by what they perceive as the likely financial rewards for it, which is completely understandable, especially when they emerge with so much debt. So I really hope and believe that if we can pivot our system to be one that values better health outcomes, that we will not only shift the focus to a much more cost-effective approach to healthcare, public health, prevention, much more cost-effective than tertiary quaternary care. Even though, of course, at some point, some subset of people will need that tertiary quaternary care, but many fewer of them will need it if we did primary care, public health, you know, everything else better. And if we can do that, then the way in which students perceive, the way in which we value different professions will be different. You know, we will value primary care considerably because, frankly, all of the systems, you know, even in Utah, when we started shifting more towards value, when Medicaid became capitated, we started needing to hire a lot more primary care docs. We valued them much more. And students will know that. Students will see that, and they can make, I hope, decisions that will reflect that and better serve our society going forward. I really hope that. And I will say that I love the fact that there are so many students, and I have been volunteering to talk with students and other student groups. So if folks are interested in that, I'm actually volunteering to do that. That's one of the silver linings of doing a book tour during a pandemic, when all we do is video conferences, that I'm getting to spend more time with students, which I actually.
So I think we're out of time, and I really am grateful for you finishing on that note. We will take you up on that, Dr. Lee. We will give you the honorary neurology diploma right now. So this has been a really great hour. It's flown by, and I've been advocating for going for another hour, but I've been told that we need to stop. So thank you so much. This has been wide-ranging. I'd like to thank the audience for the great questions, and there's so many that we couldn't ask them all, of course, but read the book, and a lot of them are addressed in that book. And Dr. Lee, thanks for the great work you're doing. Thanks for joining us. I think before everyone leaves, please answer our poll questions, our evaluation questions. So they're on the screen now. And with that, Dr. Avitzer, thank you so much. Thanks to our outstanding staff, and Dr. Lee, thank you yet again.
Thanks so much.